we're going to look at these end-of-life issues, particularly with physician-assisted suicide, from a nurse's perspective. We'll look at what are the criteria for death, how is a nurse obligated to assist their patients in the process, and then we're going to go through another poll-to-text case study. And then after that, though, I have one slide where I want to introduce you another ethical system in natural law. And I'm going to explain why I want to do that, because I think it's going to help clarify a few questions that I'm guessing are going to come up during the actual case study. So with no further ado, let's say this. So end-of-life issues. Has anybody been intimately involved yet with end-of-life issues? Like, have you been there when someone's passed? It's always difficult, right? So my wife just came home last night, and one of the people in their assisted living passed away, an elderly woman, and the husband was very upset because he was in the nursing care, and they're not allowed to stay past a certain time. And he's very upset that he can't be with his wife. You know, I've been married all these years, why can't I be with my wife? And my wife offered to bring him back personally. And then he came to her at one point and said, I think my wife's dead. So my wife goes in there, and she wasn't dead. She was breathing, so my wife was consoling him, saying, I think she's just sleeping. You know, she looks fine. Well, did it turn out that a few hours later, the poor woman did die? So they called the RN, but you know, this is why I don't go too deep into protocol, because I have no idea what the particular situation is going to be, where they're going to work. But usually the RNs would handle that from that point on, but not this time, because the woman had come into the process through hospice. So hospice had charge of that, so the RN really couldn't do anything. But somebody had to go and talk to the husband and everything else. So, you know, my point in all of this is that these end-of-life decisions, we're not always clear with what we want. So oftentimes the onus lies on the family members or the surrogates, whoever the people might be. So the nurse is the liaison, right? You're in the conversation with these people that are making determinations, particularly if the patient's incapacitated or unable to confidently speak about their own health care and such. So the text, I thought the text did a pretty good job of talking a few different ways about exactly how the nurse mediates these particular things. And the first one, as far as you being an information broker, what it particularly meant by that, you're the one that's in proximity, correct? So you're the one that's going to be talking to the patients, to the surrogates. The doctor certainly comes in and makes their own assessment. They're also going to probably ask for your assessment. How do you think about this? You're also going to be the supporter, and by that I mean there's a lot of other, I don't know how I'm going to say it, I don't want to use the word miscellaneous. Let's just say that it's a continuation of the position of a liaison between the physicians and the surrogates, for instance. So to use a personal example of my father-in-law, there were various physicians coming in with different information. And they're, you know, not to be crass, but they're not in the room very long, right? The nurse there at the station is the one that's seen this person on and off for various, you know, for 3 or 4 shifts. They're going to have a better connection. So you wind up being a supporter, and by a supporter, it's not just the clinical aspect. This is the ethical part of nursing, where you're a human being and you're treating not an illness but a person, right? So it's the empathy that you imbue. It's the idea of just having a consoling heart, right? People are fraught with fear at these particular times in their life. It's something that everybody knows that is inevitable, but it's not something we like dealing with. So the nurse is in proximity. They're going to probably look to the nurse first and foremost for a lot of, you know, so-called information, for comfort. We're not quite sure what to do here. We're not quite sure what's coming next, right? We'll talk about that a little bit later. And you could even be involved in a direct mediation. In other words, you might sense that it's time to set something up. You know, we need to talk about the next steps here and what we're going to do, particularly when patients, or the surrogates are getting what appears, at least to them, to be conflicting information. And in the end, always to advocate for what the patient wants. So I remember when my mother had come out of surgery, we knew the surgery was a decent prognosis, but the week after would be very difficult, especially with sepsis. And even then, the one surgeon wanted to do a biopsy on the lesion on their lung. And he was in, I didn't realize at the time, he was in the ICU with my mom, with a nurse talking to me on the phone. And I kept saying, why would you want to do this? And he said, well, just to see if this is cancer, what type of cancer is it? I said, if it isn't cancer, nothing will be done. If it is cancer, nothing will be done. I don't understand. Why would you want to put this woman through that again? And he goes, well, what did you want to know? And I said, what would I want, for what, curiosity's sake? And he goes, well, how about for like genetics, like for your own, your own familial history? And I said, to get cancer at 90 years old? I don't see that as an issue. Well, anyway, so nothing happened. And when they came back to the room, I said, nothing's going to happen, okay? So the nurse happened to be part of the transition team that brought my mom from the ICU back to the room, and she kind of told me on the side, because she didn't want to pretend she was like, stepping on the physician's toes, but she said, I heard everything you were saying over the phone. And I kept thinking, what is this doctor doing? So you would have that obligation to advocate for the patient. If you sense, like, in other words, I was fairly, because of what I do for a living, I was fairly articulate. Well, that doesn't make me better than anybody else, only in this particular situation I have the skills. But not everybody has those skills. You do, right? So you're going to have to ferret out, how does this person feel, and step up to the plate and say, look, this individual does not want to go through with this. Well, I really think I want to help them. Okay, well, that's paternalism. You now know that. No, we're not doing that. And even if, and we'll see with this physician-assisted suicide, if it's something you're not comfortable with, you can still, vouch out, right? So you could, by conscience, say that I don't feel compelled to do this. We had a case study like that. But nonetheless, you still advocate for the patient. Somebody who needs to help this individual, it's outside of my purview, right? That type of thing. The book also talked, I thought, mentioned a few good things that, well, let me say it this way. It mentioned a few things that were brought up in the study that nurses were not very good at, all right? In other words, things that they thought nurses had to do better. And one was to communicate, like the use of equipment. Do you know when you're giving a presentation up here, and it's always the same presentation, you feel compelled to say that, right? Well, do you know how many times you're going to repeat stuff that seems like it's simple, pimple? Why am I saying this? It gets hard for a person in any profession to realize that the individuals in front of you are hearing this for the first time. It may be simple to you, and you may have said it 30 times already today, but they're only hearing it for the first time. So I don't know if that, I didn't read through the whole study. I don't know if that's what led to part of it, but that would be psychologically at least something I would think about. That, maybe you're not explaining exactly like what the use of this equipment is, what does this do, and you know how it is. If you've already had any clinical work, the minute one of those, like an IV's empty or something, and those machines beeping, it drives the people in the room nuts. But you have to prioritize on what you're doing. You can't just go to every beeping IV machine that needs to be turned over or reset, but the people in the room, it's driving them nuts. But your lights are blinking at the station, that type of thing. So, it'd be enough at that point to communicate to the individuals, if you hear that again, we'll get here as soon as we can, but please know it's nothing vital, okay? That alone probably brings the person to a point where they're like, okay, so it's annoying, but we can live with it, that type of thing. Also, explaining the prognosis, right? So the doctor will come in and say certain things, but, they'll do their best, and they'll say, do you have any questions? But they can be a little intimidated by the physician, and they feel a little more like the nurse is more approachable. So you might be the individual that's giving them some sort of like explication on what the prognosis was, or I'll try to explain a little bit more what the physician particularly was asking if you are explaining that particular thing. Preparing family members for visits, right? So if somebody's intubated and they're unconscious or they're on high levels of morphine, you come in and they got their mouths open, their heads are back, the hoses, it could be a traumatic experience for individuals coming in to see their family members, and especially with children, right? So again, this is probably obvious stuff, but it's obvious stuff that can be overlooked very easily.
It's a really dumb question, but what does
Like, you know, they have the the tube now, okay? So, for whatever reason, right? But if you've been in a situation where you've seen somebody, because the mouth is open, it can be very dry. If it's a male, they're unshaven at this point. It could be like, oh my Lord, you know, that type of scenario for the individual. Okay, before we move on, let's talk about what exactly is the criteria for human death. You know, this has changed over time, and I know typically, like with my mother, they called it the femoral artery, but nonetheless, let's talk about what the clinical definition would be. First of all, the circulatory and respiratory functions, everything here, both of those, the whole brain death and circulatory and respiratory functions have to be complete, cessation, and irreversible, right? So they would probably do an apnea test if the person was receiving oxygen, you know, obviously we would remove it and see if the person recovers. If they don't, you know, and they might do that multiple times to make sure that the person can aspirate spontaneously. With whole brain death, we're going to say this is different than just a higher brain function. So this would include the brain stem. So you're going to see consecutive EEGs, CAT scans, and at this point, you're really relying on moral certainty. And we'll see later about experience. We all have read stories with individuals who they were told to never come out of this coma, get total brain death, and a year later they do. I read one study where it was 18 years later the person came out. Okay, but those are extraordinary. Right? Those are absolutely extraordinary. Typically, this would be the case. Now, they'd also have to make sure that there's not other factors involved. Hypothermia, because that can give you false positives. Or was the individual on some sort of, you know, pharmaceuticals or drugs that could also give you false positives or negative. You know what I mean. Do you guys kind of feel out of it today? I do. I don't know what it is. Maybe it's because we're in a transition period here. And it's like all the years that I teach all this stuff, I'm catching myself actually going back and looking at my notes and make sure I know what I'm talking about today. I don't know why that is. Anyway, this is not the same as the permanent vegetative state, which would be just the loss of the higher functions, okay? Are you familiar with the Terry Schiavo case? Anybody familiar with that? Terry Schiavo was down in Florida. The woman, for years, had been in a permanent, was it down there? Permanent vegetative state. Her husband was looking to remarry, so let's not read into the motives there. We really couldn't, but he still had custody over this woman. The parents did not. The parents wanted her to remain on NaH, artificial nutrition and hydration, but he wanted it all removed. And she, well, I'll talk a little bit from the Catholic point of view, because not only is this a Catholic institution, but 1 out of 6 hospitals in the United States are Catholic institutions. So ANH is not medicinal treatment from a Catholic bioethics standpoint. It's just food and harm. Now that doesn't mean that it's given at all costs, right? Because there could be a time where the port and entry stuff could be infected and there's nothing you can do. Or perhaps they're no longer assimilating ANH. Okay, that's aside. But just to remove it would be removing what's non-medical care. Now bioethicists are going to disagree on this, okay? But part of why we did our ethical initial systems that we tried to look at, because first of all, a person who's in a permanent vegetative state has different goals than the person who has total brain death and an irreversible cessation of respiratory and circulatory systems. This person is functioning outside of the NaH, so they're breathing on their own. Your goals are not going to be restoration of health. It's going to be to keep the person, you know, fed. You're not even keeping them alive. Well, you're keeping them alive, but you're only feeding them. That's what I'm trying to go at here. So you have to come up with some sort of criteria for personhood. I wasn't trying to be hyper-religious when I said that we don't argue about what is or is not life. We have a decent idea. In other words, to keep a person, like let's say a person was in this particular state, you can keep them on a heart and lung machine because perhaps they're donors, and you have to keep the person's body functioning to harvest the organs, but the person is dead, clinically dead. So we're not arguing about whether or not they're dead. But in the state of PVS, you have to make some sort of determination. Is this a person yet? Now you might think, well, I don't want to deal like that. But we can't have like a knee-jerk reaction or what I would call it a yuck factor to our ethics, right? When I kept saying in the beginning there's no neutral ethic, this is what I mean by that. So somebody might say, well, I would say that a person is unborn is not a person, but I'd say this is still a person, and if you're oppressed, you probably would come up with the idea that somehow they have like accumulated memories. In other words, they've accumulated worthiness of their personhood, right? But we looked at various theories on this, right? So if we hooked our memories into personhood, if we did a theoretical thing where your memories are put into something else, is that you? And if it's not you, then who is it? And if you lost your memory, are you no longer you? So all those things that seem like they might have just been, experiments, thought experiments, they have value, right? So Daniel Dennett, who understood basically like the human person as a consciousness, would see no personhood in a person in a permanent vegetative state. But somebody who Roger Scruton, who understood personhood to be something of the nature of the human individual, would say this is still a person, all right? So it's just something to keep in the back of your mind, because what we'll find here, when we're going to talk about futility here in a second, is that these are all value-based judgments. And there's no neutral value, right? So I'm guessing that there's at least some of us here that have theistic backgrounds. I'm not asking you to be dogmatic, but I'm also saying you shouldn't leave those at the door just because you're in a secular situation. That's not how the world works. Those are still part of who you are. And just because a person doesn't have a theistic background doesn't make them neutral. That's not how it works, right? One of the guys, like an advisor on my PhD, he's known for writing on the myth of secularity. There's this idea that just because a person's an atheist, they're by default don't have a horse in the race. Don't go that way, right? There is no neutral ethic, right? So we have to develop some sort of value system. What I don't want to be is dogmatic and impress something on you. I want to put it before you so that you realize you have to determine that. So when we start to talk about end-of-life issues, we're going to start talking about medical futility. But the minute we start talking about medical futility, we can't pretend that that word is just self-explanatory. If you were going to take a particular exam and somebody said, how are you going to do? It's futile. That's ambiguous. Does that mean it's certain that you're going to fail? Does that mean you think you're only have a certain chance? Are you psyching yourself out? No difference here, right? And what's futile to one person may not be futile to another person. So when your job as a nurse to be advocate for the patient is going to have to be part of the conversation to discern that for the individual. What is it that their expectations are? Are they realistic? If they're not realistic, what would be a good what would be a good transition to the next level of care, even if it's just, palliative or hospice, that type of thing. Now, I want you to give me what you think of this. Let's say a physician is going to determine whether or not a particular procedure is worth doing, or is it futile. They could say, we're going to use our experience. We've had a lot of past experiences doing this. And we're going to use that to determine whether or not this procedure will be futile or not. What do you think would be the pros and cons for that? A physician using their past experience. What do you think would be the pros and cons?
Guessing a con would be the level of experience that they have. Like
Could
be
be.
a doctor who hasn't had many cases.
Is he 32 or is he 58? Right? Good.
I guess a pro could be, it would give like the patient exact examples or comparisons and some of the results.
Yeah, it's always nice to have something that's not purely theoretical, right? Did you have your hand up?
I did, but it was.
He took your answer? Okay, so patients' health issues are often complex. So we don't always know how do they fit into what's happened before. And is what happened before isn't predicative of what's going to happen in the future. Now, it doesn't mean that this isn't a good way to start analyzing and using as a standard, but it's not as solid as a standard as we think, okay? You can look at studies. Studies have been done. Studies have shown, right? What would be the pros and cons with that? What do you think about that? The pros and cons of studies.
So like pros are you find out whatever you're trying to learn and better society and stuff, but it could also be cons. So you could exploit the people you're studying people and
Could, right? Yeah, there could be even issues with the methodology, you know. Also, we don't really know, again, do these studies, are they particular to the case that we have before us? We still have a lot of the issues, right? Again, it's good to have that, but if we're going to use that alone as a standard, right? Dramatic cases, things tug at your heart, right? I mean, first of all, there's always these scenarios where somebody was in some permanent vegetative state for 10 years and they came out. There's always situations where they were declared brain dead, and then they come out and they said they heard every conversation about it. You know, those things are real cases. They are very, very low in their occurrence, but they're dramatic and they really affect us, right? I mean, we're embodied beings. We're not Sheldons. We don't just, you know, walk around in pure rational thinking. I should say that. We don't just disengage our feelings and our emotions. That's part of who we are. But we also have to realize that they can affect our evaluation of what's going on in this particular case. Who knows? Maybe a doctor's had a run of success. Things are on a roll, but that didn't really, you know, amount to anything. It's a statistical analysis. Or maybe they have not had success and they think this one could be the one to really turn it around, right? Maybe this will, who knows? It's impossible to say. And back to statistical analysis, you know, the issue there is, okay, so like in the text, I thought it was a pretty good demonstration when they said, let's say that we're going to say, if we can determine that there's a 10% chance of survival, it's worth it. Anything below that's futile. Maybe somebody else will say, we think it's a 5% should be the cutoff. If there's a 5% chance of survival, it's at least worth doing. If below that, it's futile. You know, the text said if you just took those two basically statistics and then extrapolated them out to all the cases, how many people fall into the unknown, right? And why is 10%? Why does that become the cutoff? What's the magic number? We like round numbers? You know, that type of thing. It gets very difficult, right? So you often have individuals with multiple failing systems, and it's very difficult to compare one case to the next. And even like I was talking to the one surgeon when my mother was in the hospital, and he was asking me, like, he'd come in just to talk. And at one point I said, you're looking at my mom. He goes, well, I wanted to ask you a few things about, you know, bioethics. And we started going back and forth, and he said the way he had it done was he would work out all the various scenarios that he could envision and put percentages on them. And I said, well, but what do you have, like an accountant in the room? I mean, I wasn't trying to be a smart aleck, but how do you do that? It's one thing to say, I'm going up against this operation and it's 50-50 chance. I can digest that. But how do I digest all the other things that are going on? It gets very difficult, right? So my whole point to this is not to say that, you know, we don't have to come with some determination. But it's going to be a moral certainty. It's not going to be some scientific evaluation that we throw all these figures into a box and pull them out the other end with an answer. Because these things are not standards like we would know standards. They're the best that we have. And we might find out down the road that we were wrong in a few of them, but moral certainty is just that. We're not culpable, guilty, if we did all due diligence to try to arrive at a good particular situation. So then the text, and I'm just going to hit these real quick, said there's different types of futility. We're talking about physiological futility. We're pretty much talking about certainty. There's something that's not going to happen or going to happen. And we can be determined of that, right? If a person decides to go off of dialysis because of the burdens, you know, we know that the non-functioning, you know, kidneys are compatible with life. So there's no real issue there. Quantitative futility is going to at least give us some sort of percentages that we can work with, right? In other words, it's just we can quantify to the best that we can. It might be a little subjective. Let me say something about that word, by the way. So the word subjective can be understood in different ways. People often hear that as opinion. Well, you're just being subjective. That's not how we're using subjective here. We're using subjective here with futility. If we're advocating for the patient and the patient is competent, then it's what that subject has determined. So subjective is how it exists within the understanding of that individual, okay? If we had more time with philosophy, that's very manual Kantian, right? Qualitative futility, that's the problem here. because that's going to differ. You know, you guys, when people have an obstacle in front of them, not everybody sees the same route over it. And some people get psyched out on it, okay? I mean, that's how sports works. People rise to the occasion. So what you or I might determine what is, you know, futile as far as quality, like what will happen on the other side of this, that's going to be subjective. But again, not just opinion-based, but it's based within the individual. Somebody might say, I don't ever, like we'll look at a case study where a guy says, I like not rock climbing, I like being out in the woods, streams, but if I can't do that, it's not worth it. Okay, I think I could live without doing that, although I enjoy it, right? My father, he had a heart attack, he had a heart condition throughout he actually had a heart attack in 1972, and they gave him 6 months to live, but they knew very little about, I should say that, they knew a lot less than they do now about cardiovascular disease. So he never took care of himself and still lived in 1990. But at one point he was in a coma for 3 months, and he came out of the coma. And you could see that he had a reduction in mental function. He couldn't, like in other words, he remembered my wife, he remembered her as my girlfriend. He lost like these years. So when he revered your girlfriend, Tina, thank God he was getting her name right. That would have been really awkward, right? Call her something else. And my kid had no idea who that was, right? And he couldn't remember certain things, but he could remember from being a child, the songs his mother would sing to him in another language, you know? But the doctors told my mother he needs nursing care. There's no way he can take care of this individual. Now, if you know anything about little Italian ladies that have a lot of spit, she would know. She comes home with me. They're like, no, you don't understand, Rosie. You know, he's going to need constant care. He won't be able to clean himself, bathe himself, medication, shave. And she goes, no, he comes home with me. And they were very reluctant. And I had to step in and I had to say, she can do it. I mean, this woman is taking care of people that you don't know. My mother, twice a week, she'd go to a nursing home already and just to visit people. I mean, she had a really good heart. She'd tell me and this was like my wife works in a nursing home that's kind of like, you know, the $7,000 to $8,000 a month nursing home. So if you go to like the $3,000 to $4,000 nursing home, it's pee smells everywhere and nobody's, you know, it's terrible, right? My mother said she would go there and these women, these people would be like laying naked on pea-soaked beds. And just while they were visiting, they would just cover them with towels and such, right? So my whole point of this is my mother had whatever it took to take care of this. But she was also, you know, there was no self-esteem issues in my family because that wasn't a concern. There was deadpan stuff. So I remember my mother took this like scrapbook with all the photographs of the kids and my grandparents and all my father's brothers and sisters. And every day she would go over, you know, Charlie, this is your mom. Charlie, this is your dad. I know. Charlie, they're dead. I know they're dead. Type of thing, right? But somebody would not like that, right? That could be somebody else that's saying there's no way. That's not the type of quality I have. So do you see how this is a floating thing? So part of what a nurse does is to ferret some of this out. It becomes part of the conversation. Okay. I want to bring in how the Catholic Church would look at this. Just because, again, we're at an institution here, not just an institution, but also because 1 out of 6 hospitals are going to have some sort of affiliation. The Catholic Church is not in their bioethic evaluation using terms ordinary and extraordinary, because those terms have been co-opted. Ordinary just means what's ordinarily done. So now they'll talk about disproportionate and proportionate. So I'm not trying to be dogmatic about this, but what I'm hoping out of this is if you are Catholic, you understand it better. If you're not Catholic, you understand it better. That's all, right? So when a person has no reasonable hope, but the disproportion is just the opposite of that. I didn't see any reason to rewrite it. If a person has a reasonable hope or expectation of a benefit, and it doesn't give an excessive burden, now the burden includes expense, not just on the family, but on the entire community, right? Then you are morally expected to go after that. If it does put a burden, and it could be a financial burden, right? I mean, that could be determined by what region you're in. Not everybody has access to clinical trials, right? So like my one friend, I told you that leukemia, and wound up after they basically told him, there's nothing else we can do, there's a clinical trial available, he had to be inside, hyperbaric tube bubble for, 2-3 months. He's fine today. They keep up the testing, but he's fine. But an elderly person's not gonna have the same opportunity to enter a clinical trial like that, right? So both of those conditions would be proportional to what they did. And also, no one expects you, because you hear sometimes people say the Catholic Church expects to keep the person alive at all costs. It's not true whatsoever. And even if it's how does it affect the healthcare system? How does it affect the finances of the community? How does it affect the finances of the family? And it could be different. The family, look, people that have more money basically have the means to protect themselves from insecurities. People that don't. That may be unjust, but that also figures into proportionality. So a family who may need something that's not covered by insurance, and it's $150,000, and if they can't fundraise it somehow, they're not expected to morally, what are they supposed to do? For another family that has plenty of money, that's not a big deal. So that all depends, okay? But they'll use these terms, proportionate and disproportionate, rather than ordinary and extraordinary. So how are nurses fit into all of this? First off, when we used or talk about obligating, I want to make sure I didn't miss something that's going to wind up being on your exam or something. Okay, no, we'll leave it there. So it's educating both the family and the patients, because again, a lot of times in end-of-life issues, most of what affects us is the fear of the unknown. Death we'll accept as inevitable. Fear of unknown, not so much, right? So just to know what's coming next and know what to be expected, that's part of it. Also, to encourage, and these are in your text, but encourage them to start to at least contemplate that some of the actions that are options may have certain levels of futility to them. In other words, it's important for the patient to not have false hopes, but also to know that these may or may not really improve. And we can talk about qualitative futility. You may not come out on the other end. I mean, just so you know, here's your situation. Where they're going to educate you on what's happening, and also going to encourage you, it's time for you to start considering these. And it could be anything as simple as a DNR, right? And then to support whatever it is that they're particularly interested in. And to make sure that first of all, they're informed, but support them, and also like tying in with the communicating, to have them, meet up and facilitate any communications they have with the particular physicians. Because the reality is that, what I saw with my father-in-law was conflicting information from the attending physicians. When the one physician came in, who was the GP, who was the admitting physician, he didn't really seem to understand the severity of what's going on. Why is he not, more active? You need to get him more active. It's because he had internal bleeding, had not been discovered, right? The next physician came in and was pretty good. It's like, it's the kind of guy, you don't meet plenty of people like that, where you wish you can, duplicate them and make every doctor like that individual. And the next doctor comes in as the kidney doctor that says, look, I want to talk to you about putting him on dialysis. And I was there, and I remember saying, why is he going on dialysis? Well, we could put him on dialysis or we could not. It's really up to you. We'll support whatever you want. If he doesn't go on dialysis, obviously it's not compatible with life, so we're keeping him comfortable. Why are we talking about this now? I mean, this individual's coming out of surgery, he's still on high levels of morphine. We don't know why yet he's incoherent. And the same day we're talking about this, and when the next doctor came in and somebody brought that up, he was a little incensed. Why in God's name? We're not even near there yet. We're a month away from that. Don't even forget about that. So, but the difference is the nurse is there at the station, right? And the nurse has been on the shift for the last 4 or 5 days. They can communicate all of this. And that brings in the last part. If nothing else from this course, remember that you're always advocating. Whatever that individual wants, as long as they are competent to make the determination, then they have the right and autonomy to do that. If you have an issue with a particular treatment that's coming, then like the one case study that we brought up, then you could and should, by conscience, be able to opt out and say, I'd rather not be the one that does this. Can you bring somebody else in? And they should be able to accommodate you. But that being said, you're still there to advocate for them. And again, I go back to my mother's situation where the doctor wanted to do the biopsy, and I couldn't imagine why I was going to be doing this, right? So if you don't have a person who's assertive there, that's a surrogate or a family member, then it falls on you, okay? Any questions on this?
Can you quickly explain again what qualitative futility is? I'm just confused.
Yeah, well, qualitative futility is, when you're trying, rather than saying we have something statistical, we can say that you have a 10% chance of this or that happening. Qualitative is, how are you going to perform in your life out on the other side of this? In other words, if for you, say mobility was the cutoff, I have no family around, I don't have kids that are visiting, if I can't get around, I don't really particularly see, the benefit to getting this operation. It's going to help me get there. Somebody else might be perfectly fine with that. Like I said, I'd have no issue with that per se. So it really determines on that. It's part of a discussion. Anything else? Okay, can you get your phones? And let's do, it's Stephen Bueno 595 and then 2233s again. We'll work through this scenario, and then, like I said, when we're done with this, I just want like 10 minutes to go over something that I think is going to help. Or those, just point this over, 345? Every single time I forget. Okay, so we have a pretty, multiple issue situation here. We have a 73-year-old smoker with COPD, diabetic, lost part of the vision because of that. He has heart failure, he's on dialysis, he's on a ventilator. He's already been to the intensive care unit in the hospital multiple times. But here's a guy that loves outdoors, and he loves mountain adventures. I mean, obviously, not in his immediate future, right? He doesn't want to live with no hope of return to his favorite activity, so his quality of life is based on that standard. He doesn't want to face suffering and pain. He's clinically and severely depressed, and he just wants to die. But he wants treatment to continue because he's also terrified of a slow, painful death. The only alternative, he says, is give me enough pain medication so that you can hasten my death. And when he says hasten, he means that he should die right after the medication. So he insists that the doctor just gives him what he needs, and he can't understand this paradox that he faces. He thinks to himself, if I only lived in Oregon, I would have the right to die and be assisted in my death. But the state where he lives, he doesn't have any right, okay? So let's not worry about how clearly you understand the death, the legality of PAS in Oregon. That's a side issue. What do you think, though? I mean, regardless if you get this right or wrong, we could talk about it. So Mr. Rockland, is he right in thinking that Oregon, if he was only there, he'd be assisted in dying? You're starting to get it's always yes and no with these questions, right? Okay, let's forget about the fact he's not an Oregon resident. That would be one of the criteria, but he said if I were there. One of the issues, criteria, is he has to be able to ask this on his own, right? It can't be like an advocate, and he's there. But one of the other issues is that you have to have a terminal illness with 6 months or less to live. He does not have that. His fear is that he can't return back to, the woods and the lakes and such. So at the very least, by that criteria, even in Oregon, he would not suffice. The other one's above 18. He's certainly above that, right? That type of thing. Keep in the back of your head, too. Well, we might talk a little bit about this on Tuesday, but when we start talking about euthanasia, these are value judgments, right? And euthanasia, this is a case where we could all say we might get close to agreeing or disagreeing. But once you have the law written, it can be extended to individuals that you probably would not feel as comfortable with. Even if you were, say, pro-euthanasia. We may or may not talk about it. If I think about it, I'll try to bring something up. But I've read studies where two people that were 4 years old, twins, that were losing their eyesight, didn't live without eyesight, euthanized. 18 or 19-year-old that had severe chronic depression was told by his psychologist that he probably lived with the rest of his life, didn't want to do it. So, you know, once we start framing this in terms of the right, and I'm not here to argue about that today, we just have to be careful, because we all have these scenarios about, I would want to be like that, but those aren't the hard cases, right, that type of thing. Okay. Now, something else about this particular case study. Now, another physician, Dr. Howard Brantley, he always believed that those who are suffering anyway, in a way that cannot be resolved by normal treatment, they should be assisted in their suicide. If it were him, he would want such help. So according to his own recollection, Dr. Brantley has given a lethal dose of pain medication to 6 patients in 15 years of practice. He doesn't understand why anybody would object to this. So this is almost like a Dr. Kevorkian, if you want to think of it like that. So is it morally appropriate for Dr. Brantley to provide a lethal dose of pain medication to Mr. Rockland or any other patient? You're not getting a lot of information, not even think about this. But with euthanasia, there's active and passive, right? It's being done to you, or you're doing it to yourself. No. You're doing something that's making it happen, or you're not doing something allowing it to happen. And then there's also voluntary and involuntary. Voluntary is what we'd be talking about here. This would be voluntary active euthanasia. Involuntary would be homicide, which would be what the previous physician, if he did that without individual's knowledge, which it's happened, right? That would be involuntary active. Now, I might throw you a little bit because I'm using this case study that Dr. DeMarco put up. It's a real case study, but I left his language in there, and he talks about no life is sacred, so that might give you like a theological component to this. But the reality is that here it's B because it's typically not accepted in the healthcare field unless you're in particular states to give pain medication with the intent to kill that individual, okay? Now, if you have any questions on that, let's do one more slide because the next slide just tweaks this a little bit and probably enough to help clear it up. Let's say farther that Dr. Brantley's colleague, Dr. Tolan, he insisted assisted suicide is wrong and says let's do palliative measures. But these palliative measures hasten death. So he takes over Mr. Rockland's case and he provides a strong dose of pain medication. Mr. Rockland dies several hours later of respiratory distress, probably induced by the pain medication. Now, the wording on this is not my favorite, and I wish I would have tweaked it a little bit. So what do you think on this? This would be one, if you saw it on the final or such, I would probably accept either answer depending on how you justified your answer. Because that's, if I should have taken this slide out. The next slide's an easier one to explain. In this particular scenario, it seems like this is active euthanasia. I mean, it was almost like he did it with the intent, okay? And some of this we're reading into. Now this one clears it up a little bit, which is why I should have just left this one in. What happens if the pain relief that happens to cause death, in other words, you're trying to relieve pain, but even in that way, it still causes death. Is that the equivalent of assisted suicide? It is no. It's not assisted suicide. In other words, oftentimes the levels of pain medication is... See, the difference here would be, the difference between this and the previous slide would be if the pain medication wasn't proportionate to what the person was experiencing. In other words, they may have given them, or did give them more than was necessary to relieve the pain. Here, they're giving them enough to relieve the pain, but they still realize that that will hasten death. Okay, now, this all sounds a little confusing. which is why I wanted to follow this up with another slide. Do you have any questions before we move on? I'm hoping the next slide sort of helps. Has anybody here studied natural law? Anything about natural law? You went to a Catholic high school, maybe you heard of natural law? Okay, first of all, natural law is not the law you find out in nature, okay? So if we see animals doing something, we don't say that's natural law. Natural law is also not dogmatic in the sense this did not fall out of the sky. So the Catholic Church is a big advocate for natural law, but what's nice about this is this is based on reason, and I'll show you on natural inclinations. So I can give an entire lecture on natural law, never mention God or anything, okay? And by the way, the Stoics, the ancient Greeks, were advocates of natural law. So this is not something new, it's something that the Catholic Church developed. But what it's really based on is like, if we can determine the design of something, if we can figure out the design of something, we can figure out what's good for that design, right? So did anybody watch Pawn Stars at all? You know that show? You guys like that? So they bring stuff up, and half the time what did they say? Like, what is this, right? So what do? They start doing? They tinker with it. They might pull it apart. What they're trying to do is determine the design of it. If they can figure out the design, they can figure out what it's used for. And if they can figure out what it's used for, then they can figure out that anything that good that helps it be used for that, that's good, right? So in essence, we're going to try to figure out, like, how would we determine ethically, is there a distinction between intending to hasten death and just accepting your own finality of our death, right? Because those are two different things. And here's something else too. I was listening to this podcast on NPR last week, and it was about this biologist who they're studying longevity and the genes that affect death, right? And let me put it this way, age-related illnesses. So a lot of our illnesses are just old age, they come. So they found this worm that has a 3-week lifespan, and they tweaked its genetics so that it would live 6 weeks. Now, they're wondering, what could we do with humans? Now, this isn't about making any human immoral, but could we inevitably have a human that lives to 150 in relatively good health? It's funny, the people that were calling in were all saying, no way, I don't want to live that long. I'm thinking, you know, I have no retirement. I'm working up until the day I die. I don't want to work 149 years. That's what I'm thinking, you know. But what's interesting is that the biologist kept saying, and I guess they did TED Talks and such, he said, we're treating death like a disease, and we're going to cure it. And I thought, the philosophical background in me says, you don't understand the human person. Because if there's no death, then what is our meaning to life? I mean, if we don't have some finality there, we don't really make meaningful discriminations up to that point, right? That's a whole side issue. But here's how natural law is going to play out. What you have to do is you have to determine understanding the human person. This isn't complex. You own a car, every 3,000 to 4,000 miles you change the oil, or should have the oil changed. You don't do that because it's written in the manual, because you think it's a rule that GM made up. You know that if you don't change the oil in your car, your engine's going to seize and you're going to be a pedestrian. So what's good for the car is that maintenance. The nature of the car determines what you do, okay? That's how this works. So if we come up with a design of the human person, and in bioethics, with the physiological design, right? So like a little side issue, not to sound salacious, but I've had people in the past try to catch me and say, well, why would like healthcare cover, say, medicines that treat erectile dysfunction, but they wouldn't, cover things that are, say, contraceptive? And I said, well, let's not get into all the side arguments. I said, well, let me frame the argument for you. You're comparing both those things because they tend to be involved with the sexual reproductive act. But they're two different things. Erectile dysfunction, to cure that, is the restoration of the function of an organ. That in itself is good. It doesn't matter what you think about the other thing. That has nothing to do with the restoration of the function of an organ. So we're not even comparing two things on the same plane, right? One has to do with trying to rest. It's the same reason why, if we could find a way to treat somebody's kidney that has, a kidney disease, all we're trying to do is bring back the function of that organ, right? So we look at the design of the human person, we determine what's good with this human person. So it comes up with this and the converse of this. If X is proper N, a goal for the human person, then we ought to do X. If X is not a proper goal for the human person, then we shouldn't do X. If changing the oil is good for your car, then we should change oil. If not changing your oil is not good for the car, then we should make sure we don't do that, right? So we try to do it this way. Now, the reason why this is not dogmatic is because natural law is double negative, but it's purposeful double negative. Natural law is that which you cannot not know. There's no way you cannot not know this, right? Which is why the Catholic Church bases their bioethics on natural law, and not just dogmatically, so that way I can have a conversation with an atheist, a Muslim, it doesn't matter. We're only talking about something that I don't think anybody here is going to argue about this, right? So these are known as the primary precepts. They are the things that nobody has to tell you, and you will go after them. The first is to choose good and avoid evil. Now, forget about moral good and moral evil. Everybody does what they find good for themselves, right? A person who has an adulterous affair does not say, I want to ruin my family's life and screw up my relationship with my wife. They think they're satisfying some good. So it could be a false good, but they still are choosing it, right? So we all will choose good and avoid evil. And the principalism of non-maleficence and beneficence are based on this, right? It's known as the first principle of morality. Do good and avoid evil. Nobody really says tell us that. If you think that that's not true, then just think of like, when we were real little and we did something bad, didn't we lie immediately? What inclined us to lie? We were covering something up because we knew something was not good, right? Which brings us to the next one, seek truth. We're inquisitive beings. Forget about at the college level, we want the truth. Nobody wants falsehood. We're always trying to find out, is that really so, right? Preserve life. If you were like 6 years old and playing in the pool with your siblings or your cousins, and they were holding you under the water, your mother or dad weren't there on the side of the pool going, did you say that did they understand that they shouldn't die? Did they understand? You never have to explain that. Everybody automatically tries to preserve your life. It's a natural inclination, right? Also, procreation. Nobody has to tell us about this. And by the way, I didn't put it up there because it didn't fit, but it's education, right? So the human species, we don't come out of the womb ready for the world, right? There's a lot of education, not only formal, a lot of education within family and cultural that has to occur. So nobody has to tell us that. It's like eating, right? Could you imagine if both food and sex, like if sex was just painful and nobody wanted it, and if food was all tasted like wax, our species would be done in a very short amount of time, right? So these are good things. And the last one is to be relational in society. Nobody needs to tell us that, that we need others, okay? So what we do then is we take these 5 known as the primary precepts, and then we combine this with reason. And then we can develop other things, right? So you can make an argument that murder is wrong. Somebody might say, yeah, but it's one of the commandments. Forget about that. We don't need that to tell us that murder is wrong. How do I know murder is wrong by natural law? Because I know that I have to preserve my life. I know you have to preserve your life. It doesn't take too much more reasoning to realize you're another me and I'm another you. So I should help you preserve your life, and murder therefore is wrong. You can make that jump just using a little bit of reason. You could also, like if you want to talk about issues of immigration, racism, cultural issues, you can do the same thing with society, right? We can work this out. Those are all known as secondary precepts. There are remote precepts that are still true and knowable, but they're more difficult. And you've already learned one of those, the principle of double effect. The principle of double effect is based on natural law reasoning, which is interesting that even the secular society has adapted it because of that. In other words, I'm not trying to tease anybody else's belief system, but if a person was like a fundamentalist Christian, they would have to find a way to base all their bioethics on biblical principles. The Catholic Church doesn't do that. The Catholic Church says, when we engage in the natural law, we're going to base the natural law on a person's inclinations, that which you cannot not know, and then we're going to put reason to bear on it, and we're going to develop and extrapolate there on out, right? So it's known as the bridge. Now, let me give you, on top, any questions on that? Let me tell you about another ethical system. So we learned about utilitarianism, we didn't proportion, but we learned about deontology, virtue ethics, and principalism. And there's a lot of variations in all of those, right? There's a lot of variations. This is another way to do it. This is how to determine what happens in a particular act. In other words, if you ever wonder, like, how would somebody, like, even with a natural law Catholic background, how would they determine is that right or wrong? We would say, is that licit or illicit? They would do it by using these three fonts, right? Like if I wanted to sound really important, I would explain to you this is the finis operis and the finis operatus. It's what, why don't we do this? This is how I do want to show it. The object of the act, what's your goal? It's the what. What are you doing? Now you can't tell this by looking at it from the outside, right? So if somebody has been given too much pain medication and it's causing them to die, and somebody's given pain medication and in the course of that they've died, their death was hastened, it looks the same. Like, for instance, like, some people will think that this type of Catholic ethics could be relative, and it's not. Like, a friend will come up to me and say, is it licit for two people that are married to have sexual intercourse? My answer is, I don't know. How can you not know? Are they married? Oh. Yes, they're married. Is it licit? I still don't know. How can you not know? Are they married to each other? Yes, they're married to each other. Is it licit? I still don't know. How can you not know? Is it consensual? Do you see all those things? I've added something, but I've changed what is happening. I went from making love to adultery to rape. They all have different words. That's how we know them, right? So those words were developed because there's something different that's happening there, right? The why is the intention. What is it that the person intends to do? And then the who, the what, the where, and the when are all the circumstances. So in our case with euthanasia, it's COPD, it's the fact that the guy doesn't want to not have to be able to go and spend time on the mountains and such, all those things. Now here's what's important. For the act itself to be good or illicit, all three have to be good or illicit. If any one of them are off by, it's illicit by defect, right? So therefore, a person, which we may not know, gives the individual extra morphine, hopes they got it. Regardless of what we know, that was an illicit act. Morally, we're not talking legally here, okay? Now, it's important for all of us to develop some sort of value system, right? So I just want to reiterate again, there's no default ethic. We have to come up with something. We don't want to be psychologically schizophrenic where we're just doing case by case because we're going to go all over the board. Not only can you get yourself in legal trouble, but you're going to put yourself in psychological discontinuity to the point where it's going to shorten your own mental health span and your enjoyment in your profession. So you develop some sort of morality, but it's based on how do I determine what is good? Am I going to be utilitarian? Am I going to be a deontologist? Am I going to be a principalist? Am I going to use this morality act? Am I going to try to form it by natural law? Am I just going to go by authority? I'll do whatever my particular institution allows me to do. I mean, all these things are ways that we develop, but we're always placing value in something, and we've got to get beyond the point that we think that somehow there's a neutral value. You know, every rule is in a position. Every time you go to a stop sign and stop, you're following somebody else's imposed rule on you. You're accepting it because you think it's good for the intersection for us, the traffic to flow safely, so I accept that. But that's how we are in ethics. If we're trying to say that you need to develop the ethical, and you add to the ethical ethos of the particular institution you're in, it's the same way. Do you not have concern for that particular environment? Do you not want things to flow steadily and freely there? Well, the ethic determines that. There's no default one. We can't just say, well, so be it, that type of thing. Any questions on that? Okay, this is the last thing, and then we'll call it. And then I just want a minute before you're out of here. If you work in a Catholic institution, there's going to be an added thing that will determine your actions within the institution. It really determines the institution's actions. It's known as the ERS, the Ethical and Religious Directives. It has a lot to do with how hospitals will cooperate with other institutions that may go against particular principles that they have and such. But they would define euthanasia as an action or omission that of itself or by intention causes death in order to alleviate suffering, right? So if you know anything about etymology, it's the eu, it's like the good, or thanatos, right, the death. It's like a mercy death. So it's not a new phenomenon, it's like, how do we understand it? So we have to try to ferret out, is what we're doing euthanasia, the difference between, you know, intending to hasten death by object is euthanasia. If we are trying to give palliative care and realizing that the care itself is going to hasten death, but we don't intend it, then all we're trying to do is we're accepting our own mortality. Those are two different objects. They look the same, right? And we may not even know the entire intention of the people involved, but that's how we would do it. So the healthcare institution can never condone or participate in euthanasia, assisted suicide, and so on. Dying patients who request euthanasia obviously should be given loving care, psychological, spiritual support, and appropriate remedies for pain and such. So if you're in a secular institution and you're involved in some scenario that's close to here and that goes against your particular ethos and ethic, you should be able to opt out by conscience. I think that's only fair. I don't wish to be involved in any of this, you know, or in such. Nonetheless, okay, we're going to do more on this on Tuesday, but do you have any questions overall?